warm welcome. Well, things are running a little bit late, and it was quite an enjoyable walk over here. So we're starting a little bit late here as well, but of course this is one of my favorite sessions when we talk about controversies, and we truly have debate and people who really know how to debate. So I'm really happy that more and more people are joining. And also really happy to see that for the first debate that's going to be about TAVR, that both the people that are going to be pro-con are here. So I would like to start with Dr. Mayra Guerrero, who will actually plead that TAVR should be the first option in a healthy 60-year-old with AS.
Thank you very much. Good morning. Well, thank you for the invitation. So, please, raise your hands if you're 60 years or younger in the audience. Please raise your hands if you're 60 years or younger. Everyone. Good. Now, imagine you have aortic stenosis now, and you have to make a decision. I hope to convince you in the next 10 minutes that TAVR is the first option. These are my disclosures. The most important disclosure is I'm with all of you. I'm not 60 yet, but if I needed AVR now, I would choose TAVR if I had favorable anatomy. The key for the rest of the discussion is we're talking favorable anatomy, right? Not calcified bicuspid valves or unfavorable anatomy. And I can give you many reasons why, but I'm just going to focus on three. I'm going to give you my three main reasons why TAVR is the best option if the anatomy is favorable. And one is TAVR has lower procedural risk with at least the same benefit as SAVR. TAVR has faster recovery and shorter length of stay. And to me, lower stroke risk and faster recovery are extremely important for young patients or young people like you who are at the peak of their careers and their performance. So very important. And number three is redo TAVR is an option when, if needed, for structural valve deterioration. You probably were at the afternoon lunch session yesterday where they were discussing the Ross procedure and other options, and I heard more than once two different speakers saying, well, redo surgery, it's not considered bad, if it happens after 20 years. I agree with that. I think if we get to redo something, it's good news. We're alive. The patient is alive. So I would like to extrapolate that here. If you need to repeat TAVR, and that's an option, that's not necessarily bad. So these are the procedural complications in randomized low-risk TAVR trials that have shown that TAVR is associated with lower or equal mortality at 1 year, 5 years, and now up to 10 years. Lower or equal stroke rates, lower rehospitalization rates, lower rates of atrial fibrillation. So who wants atrial fibrillation? I don't. Shorter length of stay, similar reintervention rates, yes, higher pacemaker rates with a self-expandable technology, and slightly higher thrombosis rates in partner 3, which makes me think that valve thrombosis really more frequent after TAVR, or more patients after SAVR develop atrial fibrillation and therefore receive long-term anticoagulation, which may be artificially lowering the rate of thrombosis. I don't know. I'll just leave that question for all of us to think about that. So the primary endpoint of death, stroke, or rehospitalization at 1 year in the partner 3 low-risk trials was twice as high in patients treated with SAVR, 15.1% versus 8.1%, and that met superiority criteria. This is at 1 year. Now, death from any cause was not statistically significant, but it's 2.5 times higher with SAVR than TAVR. And very important for me, stroke rates were 4 times higher, 2.4% at 30 days, 2.4% versus 0.6% with TAVR. At 1 year, that difference was not statistically significant, but nonetheless 3 times higher with TAVR. Rehospitalizations rates were higher also with surgery. And the key secondary endpoints in this trial were in favor of TAVR. For example, new-onset atrial fibrillation, 5% with TAVR versus nearly 40% with SAVR, so 8 times higher. The hospitalization length was 3 days versus 7 days with surgery, and this is years ago. Now the hospital stays are just 1 day. Sometimes patients go home same day. The primary endpoint, I already told you, twice as high with SAVR compared with TAVR. Now, death and quality of life score less than 45 was 3.9% with TAVR and almost 10 times higher or 8 times higher with surgery, 30%. Death or stroke at 30 days, 3 times higher with SAVR versus TAVR, and stroke at 30 days, 4 times higher with SAVR versus TAVR. Now, at 5 years, the primary endpoint of death, stroke, or rehospitalization were not statistically different. The p-value was 0.07, but numerically lower for TAVR. Death from any cause at 5 years was similar. And the valve performance remained stable at 5 years with similar gradients and similar aortic valve areas at 5 years. Now, the Evolute trial has kind of a similar story where the primary endpoint of death or disabling stroke at 2 years was relatively similar, numerically lower in TAVR, and it met the non-inferiority criteria. These are key secondary endpoints, and yet I just would like to highlight again, atrial fibrillation was 9.8% versus 38%, and pacemaker requirement was higher with TAVR. So atrial fibrillation lower with TAVR, but pacemaker requirement was higher with TAVR. And these are the 5-year outcomes that were published a few days ago that shows essentially identical all-cause mortality or disabling stroke at 5 years, so not inferior to SAVR. And the valve performance was superior in patients who were treated with TAVR, who had higher or greater valve areas and lower gradients at 5 years. So you have data with durability at 5 years and actually superior for patients who were treated with TAVR. Now, the Notion 2 trial, as you know, also evaluated low-risk patients. The difference here is they did not exclude bicuspid valves. So partner 3 in the Evolute low risk excluded patients with bicuspid valves. Here, bicuspid valves were not excluded. And in Notion 2, they evaluate younger patients, younger than 75, although the mean age ended up being 71, so not very young. And the primary endpoint of all-cause mortality, stroke, or rehospitalization in patients who have tri-leaflet aortic valves was similar at 1 year. But in the small number of patients, only 100 patients who had bicuspid valves, it was numerically higher for patients who were treated with TAVR. But it was not statistically significant, perhaps due to the low sample size. So it just leaves something to think about, but does not confirm these findings. And then they did a sub-study analysis in patients who were younger than 70. We still are not at 60, but at least younger than 70. And on the left, you see the number of those patients it's a small sample, 81 patients with TAVR, 77 with SAVR. And the primary endpoint at 1 year was numerically higher for patients who were treated with TAVR, although did not reach statistical significance, also perhaps due to a small sample size. And when they compared patients who had tricuspid or tri-leaflet aortic valves, TAVR or SAVR, there was not really a big difference, but for patients who had bicuspid aortic valves, those younger patients with bicuspid valves, for those surgery was better for those patients. So about durability, the longest durability data, I already showed you 5 years. On the other ones, the longest durability is the 10-year outcomes of the Notion trial, where they have shown that the primary endpoint of this analysis of all-cause mortality, stroke, or MI were identical in patients with SAVR or TAVR. And importantly, the valve performance was superior for patients who were treated with TAVR. Let me go back, I'm sorry. Where those patients treated with TAVR had lower gradients and also had greater or larger valve areas with TAVR. And importantly, bioprosthetic valve dysfunction, the rates of those were higher in patients who were treated with SAVR, but this was primarily driven by patient prosthesis mismatch. So we're not talking structural valve deterioration, we're talking about non-structural valve deterioration, but there were higher rates of patient prosthesis mismatch. And the real rates of bioprosthetic valve failure, that led to valve-related death or reintervention, those were not different, but at least patient prosthesis mismatch was greater in patients treated with SAVR. So with all that, I have good reasons to believe that now my TAVR is going to last me at least 10 years. And if it fails, we can do this again. The Redo TAVR International Registry has shown that TAVR in TAVR has similar outcomes that TAVR in SAVR with similar mortality rates, actually numerically lower, perhaps for well, not this one, that's numerically lower. This is identical, but what is better for TAV and TAV is the performance. Lower gradients in TAV and TAV, and greater valve areas in TAV and TAV compared with TAVR in surgical valves. So it is an option if the anatomy is favorable. We also know that on partner 3, we included low risk to intermediate risk patients for valve in valve. These patients are young, 67 years. We included 100 patients, and the primary endpoint at 1 year was all-cause mortality in stroke. That was 2.1%. That was driven by stroke rates because nobody died. All-cause mortality in these patients who had a prior surgery and were treated with TAVR and SAVR, the all-cause mortality was 0. And I see Chris Malesri is here. He presented the 5-year outcomes at CRT a few days ago, where we can see the total rates of combined endpoint of death or stroke at 5 years. They're still low, like 14%, and death is 11.5%. In similar, like in other studies, the performance has remained stable at 5 years with adequate gradients and valve areas. So it's an option if the anatomy is favorable. But what if the anatomy is not favorable? We know that for patients who have high risk of coronary occlusion, now there are techniques that you can utilize to decrease the risk of coronary obstruction, like the basilica that has shown success in more than 90% of the patients, where you lacerate the leaflet to increase flow to the coronaries, and then the shortcut device, so specific devices designed to decrease the risk of coronary obstruction. This device already received approval in the US. You also have devices or techniques to remove the leaflet, not just to lacerate, like the cathedral device, the cathedral procedure, where you lacerate and remove, actually excise a piece of leaflet to improve the flow to the coronaries. And there are several devices that are already being evaluated, specifically designed to remove a piece of the leaflet, like you see in this particular device, and there are others. So these are my 3 reasons why I think TAVR would be the best option for me when I'm 60 and healthy and I need AVR. One is TAVR has lower procedural risk and at least the same benefit as SAVR. And the data is with similar durability up to 10 years. And faster recovery with lower stroke rate and faster recovery are extremely important for young patients who are at the peak of their careers and performance, like all of you in this room. And the last one, redo TAVR is an option when, if needed, for structural valve deterioration. So those are my 3 reasons, and I'll stop here. Thank you.
Thank you very much, Dr. Guerrero. And now I'd like to invite to the podium Joe Bavaria. And of course, Joe is telling us why TAVR should never be considered in a healthy 60-year-old with AS. Looking forward to that.
That's not it. That's not it. That's it. Okay, well, thank you very much for inviting me to do this. So this is the debate. I'm just glad I got this side. These are my disclosures. You also note in the disclosures that I was a past chairman of the TVT registry, so I have inside knowledge. I was also the chair of the Force Society Cardiology, Cardiac Surgery Institutional and Operator Writing Committee, and I've been the primary investigator for every single trial, including Partner 1 and Partner 2, which is the original stuff. Also, my disclosures, I love TAVR. I was there at the beginning, and I totally believe it's revolutionary. But, background, set the stage. This is the recovery trial. This is a prospective randomized trial of AVR and AS. This is standard AVR, and what you see there, this is a New England Journal of Medicine paper. This got into the guidelines, was presented at the American Heart in one of the main stages. And you can see there where the arrow is, SAVR is great. These were low risk, STS score about 1, 0 30-day AVR deaths, and 0 CV deaths up until greater than 3 years where the arrow is. So in standard low risk cases, in this particular trial, this is really, really great news. This is the 5-year outcomes following bicuspid aortic valve in the COMMENCE trial, which is one of the large FDA IDE trials, $50-60 million trial, not one of these trials coming out of a single center, and for BAV. And what we should also know for BAV anyway, this is kind of interesting knowledge, is that for 40 millimeter gradient with either TAV or BAV, a BAV has 2.5 times the calcium load. And this is really, really important for TAVR. And what you see here is that the mortality rate at 5 years is only 4%, and valve-related mortality rate was only 2%, and structural valve deterioration was 0 at 5 years in the BAV cohort of 214 patients, so it's not a small cohort of BAV patients. So BAV series at 5 years, 4.1% mortality and 0 structural valve deterioration. Paravalvular leak is almost 0. You can see the BAV on the 5-year line is, it's almost hard to see the yellow line. So it's like 1% maybe is the paravalvular leak rate in this trial, which has CEC adjudication and was an FDA IDE trial. And as we all know, BAV paravalvular leaks are very high. So this is the kind of the 2-year data. We're going to get into this. This is the death and disabling stroke of partner 3, low risk. And you can see at that time we were saying, oh, we're going to have a crossover at 3 years. The answer is yes, we did. Mean age was 72.5. And then this is the looking at the partner trial versus the Evolute trial, again at 2 years and 3 years. And one of the things you can see here is the red things. At 2 years, the surgical arm of the partner trial was only a 3.8% mortality, death or disabling stroke. And so if you look at the Commence trial at the same 2-year mark was 3%. And you look at for some reason, when you look at the Evolute trial, it's 6.3%. So there's something going on here in the surgical arm of the Evolute trial. I'm not 100% sure I really understand it. So why is the AVR data in the Evolute low risk so much worse than P3, Commence, and even Paragon, which was another FDA IDE trial with the Medtronic valve? I don't know the answer. So the mean gradients in the partner trial are actually lower with SAVR for the first time, and Commence valves were even better at 10.2 compared to 11.8 at 2 years. This is all at 2 years. Paravalvular leaks, you can see that there's just a dramatic difference in all these trials, and this is mild PVL is 10 times higher in the TAVI group. You can see the paravalvular leakage rate at 5 years in the Commence trial is almost 0. It was 2% at 5 years, 2% at 5 years. So basically minimal paravalvular leaks over time. Now when we look at TAVI in the TVT registry with hundreds and hundreds of thousands of patients, okay, we see a couple of trends that are not cool. This is real-world TAVI clinical outcomes with over 600,000 or even 700,000 patients now. And what you see here is stroke. Now, stroke in TAVI, unfortunately, 30-day stroke rates are very flat. There's been no real change in 8 years. And this is incredibly important as we go into more low-risk cases. What's very interesting is that this is a platform issue. Okay? There's not that much difference in the stroke rates with low-risk patients, intermediate-risk patients, and even high-risk patients. Okay, it's a little bit different, but not that much different, which is actually worrisome in the sense that it may be a platform problem. Even this is even a low-risk patients, the in-hospital. We don't even have the 30-day, but in-hospital rates were 1%. So the 30-day rates are even higher. Pacemaker. This is the TAVI pacemaker, 500,000, 600,000 patients. And what you can see is that the 30-day pacemaker rate is 10%. Hasn't really come down that much. So 30-day equals 9.5% new pacemakers. Important as it is well known that pacemaker in younger patients that are low risk die earlier. There's been actually not that much change in 9 years. Again, a platform problem. Now, when you look at low risk patients in the TVT registry, it's still 8%. Okay, so it's only 1%, 1.5% lower than in the high-risk patients. Again, a platform problem. So this background that I just showed you informed the guidelines. So the valve guidelines. So Myra gets up here and tells you all this stuff, okay? But guess what? There is no class 1 indication for TAVR in less than 65 in the American guidelines. and less than 75 in the European guidelines. Why is this? Because there is no data. There's nothing strong enough to even get into the guidelines in a 60-year-old healthy patient. Let's just remember that. It's almost malpractice. So despite this, there is a reality and there are practice patterns. This is a slide that's actually from me that people will look at. This is the aortic valve universe slide from the TVT and STS databases, and you can see TAVR's on the way up. And it surpassed all AVRs in 2019 in the United States. Here's a more interesting slide maybe, showing that 1/3, about 30% of TAVI in the United States and the TVT registry is in low-risk patients with STS less than 3. So it is being used. That's the reality. So after the guidelines of 2020 in the US and 2021 in Europe, there was an explosion of information. Some of it we just saw. Quo Vadis, what's down the road? What does it look like? So first, this is the big paper from the STS database looking at valve replacement, surgical valve replacement in low-risk patients. Okay, a contemporary trial benchmark. And this is the inclusion-exclusion kind of, the consort diagram, but the bottom line is that these are the exact inclusion-exclusion criteria for FDA IDE clinical low-risk TAVI trials. This is real-world data, 43,000 patients, very big data. And what they saw is that the survival following SAVR is 93% at 5 years. So this is better than any of the trials that we see. Now, when we look at even the 65 to 74 group, because we weren't even looking at patients 60 years old, there's a 95% survival rate at 5 years in this big data set, which was analyzed to be exactly the same entry and exclusion criteria as the TAVI trials. So this is really interesting data. Now, this was completely corroborated. This data set was completely corroborated with the FDA IDE clinical trials. So this is the 7-year commenced data from the FDA IDE trial of the Edwards regular surgical valve for all patients. And what you see is a 14% all-cause all-cause mortality at 7 years. It's actually 7.7. And that is outstanding. And there was only 2 structural valve deteriorations in the entire group at 7 years. These are only 2 re-ops. Echo-derived mean gradients had total stability over 7 years with low mean gradients less than 10 in the newest trial of surgical valves. And again, perivalvular leakage rates are basically off the charts in a low sense. You can barely even see it. Even at 7 years. Basically, incredibly low perivalvular leak rates, literally 10 to 15 times lower than in TAVI. These are actually a little bit older patients in the sense that they're 60, I think this was 67, this particular trial was the average age. Now, this is not just the COMMENCE trial and the STS big data set. This is actually from Los Angeles looking at this. This is BAVs, isolated AVR. And you can see there's 402 isolated AVRs. The results were unbelievable. 0.2% mortality for isolated BAV AVR, 0.7% stroke rate. These are all young patients, 60 years old, just like the patient we're supposed to talk about, and a 4.2% pacemaker rate. So what about CCT and ACC highlights? And we just saw some of this. So here's the PARTNER 3 trial, average age 73 years old. So we're not talking about 60-year-olds. This data set is for 73-year-olds. And there's a couple interesting things. Number one, the crossover happened at 3 years, just like we thought, 2.5 years. And the other thing is, if you look at that little arrow on the right, something happened. I'm not going to tell you what. I was there. But you can see that as a step up to 8.2% for a p-value of 0.35. Now, I don't know you guys, but I happen to look at the FDA data set, which is public, at the FDA, at the 6-year data. It probably won't be published, but it crosses over. Just everybody should know that. Crosses over even more. Okay, all stroke equal. See that? Note that the COMMENCE AVR trial stroke rate was 5.5% at 5 years, so it's pretty similar. This is the valve thrombosis rate. I don't know where you got that data from, Myra. Okay, I'm not quite sure I understand that, but here's the real data. Here's the real slide. It was a hidden slide. Okay, this was not presented at the ACC, okay, or TCT, but here it is. 1 event in the surgery group, 13 events in 12 patients TAVR group. Valve thrombosis 12 times higher in the TAVI group. There's the data. Don't even have to even just look at it. No, I'm going to just be like an English like at Wimbledon. I'm going to stay silent for 1 second. Just read it. Okay, mean gradients out to 5 years are the same. As you can see, are pretty close to the same, but actually do favor, in this particular case, favor SAVR. Paravalvular leak rate, again, 10 times difference. We all know that makes a difference. Now, here's the primary endpoint, looking at the 5-year data set. Now, what happened here in this, what's a little bit worrisome about this slide, in the Evolute data, even though we already know that the surgical arm of the Evolute data is pathetic, okay, is that all of a sudden something happened between 4 and 5 years. I'm not sure I know exactly what happened in the Evolute trial. In the TAVI arm, went from, it really is closing in fast. So it's equal, you can see the p-value of 0.5. So we'll see what happens in this at 6 years. Now, again, the 4-year surgical AVR mortality in Evolute, surgical mortality was 12.1%. In P3 was 5.6%. It commenced 6%. STS big data 5%. Even in Paragon it was 9%. And every single one of these trials, all 5 of them had an STS score of 2.0. All 5 of them had exactly the same STS score. So this is the Evolute trial looking at this, and what we have is a PVL rate that's 20 times higher than the surgical AVR, 20 times. Pacemaker rate in this trial was 24%, 5 times higher than the commenced AVR FDA trial. These trials were not BAV and had an average age of 73, not 60. So here's the Notion 2 trial. And you saw the Notion 2 trial, and this is only 1-year data. We're talking about crossovers at 6 months, okay? Crossovers at 6 months. Death or disabling stroke, rehospitalization is kind of soft, especially in the beginning, and always penalizes the surgical arm in the first 30 days. So you can see that surgery is already better than TAVI, even at 12 months with a 6-month crossover. This is not going to look good. The Notion 2 trial is not going to look good. This is Dedicate. Dedicate is pretty ugly, but P3 was 5.8%, so I'm not sure why SAVR is so high in Dedicate. I just don't understand it, but it is an important trial. So lastly, the great majority of 60-year-old patients are going to have a BAV. Can we really treat this with a TAVR well, what you see in this picture? So this is Lars Syndergaard, a good friend of mine, one of the great interventional cardiologists of the world, and this is his editorial comment. Pacemaker rate is too high, it's 18%, and paravalvular leak rate is still too high, 12% for TAVR and bicuspid valves. This is Lars Syndergaard speaking, not me. This is a meta-analysis of all BAV TAVIs, and what you see here, this is the consort diagram, but here's the important data. 30-day mortality, PVLs greater than 3, 1-year mortality, and stroke. All of them greater with TAVR than BAV in this large meta-analysis. Again, this is the Notion trial. You saw this already for bicuspids, and it's pretty dramatic. We're talking about hazard ratios of 3.8 and hazard ratio of 3.1. So these are really not good. So I'll finish up with my own personal experience and how I think about this. This is my BAV. I looked at 415 BAVs that I did between 11 and 18. This is during the TAVR era. And the bottom line is BAV with aortic stenosis only. And you can see that 2 of the 3 deaths were AVR cabbages. And the mean grade was 5.9. Average valve size was 27. PVL weight was basically 0. So what happens when our 60-year-old needs to redo? Here's the data. The fact of the matter is, from the STS database, it has come down a little bit from 20% or so, 18. But the mortality rate's been stuck between 12 and 15% for the last few years. This is the redo AVR after TAVR data. So we should be very careful with TAVI in patients over 60 years of age, especially in BAV patients, if they are operative candidates, which they usually are, and especially in low-risk patients. My choice is a big surgical aortic valve with subsequent valve-in-valve TAVR. Give them the best shot at the beginning. Thank you very much. Time for discussion.
Thank you very much. As usual, lots of data from both sides, I think. Are there any provocative questions from the audience right now? Please
Yes.
state your name.
Yeah, Jose Rodriguez, USA. I have a bias. I'm a surgeon. I'm still convinced that surgical valve will be for a 60-year-old younger. Pacemaker is permanent. Paravalvular leak is permanent. Atrial fibrillation, yes, is more common after heart surgery, but 90% recover in 1 month to 6 weeks. So it's not permanent atrial fibrillation. I believe that stroke rate, a permanent pacemaker can be lower, should be less than 1% if the surgeon is meticulous. And now with minimally invasive surgery, you can enlarge the root, minimally invasive. You can put you can put a big valve, a 23 and higher for a future TAVI. Minimally invasive surgery will have those patients back in track. My last 3 minimally invasive surgery in 3 days went home. One was a root enlargement. So yes, if we, the surgeons, keep putting a bigger valve, meticulous to avoid pacemaker needs, less than 60 years old, even more, maybe less than 65 and 70 years old, always should get a surgical valve in selected patients.
Can I just make a comment? Is this on? Yeah, just a comment, because I think we're running out of time, but just a quick reply. I really think that the one thing we can agree on is that there's no data. So each of us have our own biases because we have seen, stories on both sides. But I think the one thing we can agree on is that there's no data. And we should have a randomized prospective clinical trial with contemporary outcomes, like the better surgical outcomes that you mentioned in other surgical trials. And, that's what we are proposing, actually, before things get out of control, like it got out of control in the U.S. And if it's going to happen, because it's happening, might as well do it in an organized way to collect data to better inform our patients or ourselves when we need AVR in the future. Yoshi.
So quick comment about the Notion 2 trial. So I've spoken to Ole de Bakker, who was the PI for that trial, and what he was saying is that in that trial, what was really special was that even on a borderline TAVR case, there are some bicuspids that are fine for TAVR, there are some anatomies that are not. So like calcified raphe is one of the risk factors. But that Notion 2 trial, they were very liberal on enrolling those patients in. That's why they saw a lot of paravalvular leaks. That's why there were statistical significance on the outcome differences. So I counter-argue with you, Myra. If we do a clinical randomized control study, if you don't design it well, if you just select the anatomical suitable patients for TAVR, we're going to give a wrong message to the public, because I think a lot of the general physicians that do these procedures won't be able to tell that difference. There was a publication in circulation that said the TVT registry showed that the real-life TAVR outcomes were worse than the trial outcomes. And there are some warning signs about that. So we have to be very careful, and I think the design of that trial is going to be very, very crucial. But I'll be supportive, though.
Absolutely agree. And I think we need 2 trials, one for bicuspids, very carefully designed to select the correct anatomy, and another one for younger patients who don't have a bicuspid valve. And data from the National Inpatient Sample Database in the U.S. show that actually, contrary to common belief, most of the patients who were younger than 65 did not have bicuspid valves. It could be...
Yeah, that's a good point. One thing about that is about the data, is that we have the California database saying it's 47% or under 65. But we also have this NIS at 5 or 6% or something like that, right? Between 5 and 10%. So this is something that we can easily answer at the TVT database, which I'm going to answer tomorrow or Monday. So we can figure this out on Monday, okay? Actually, what is the percentage of patients under 60 that get TAVR in the United States of America through the TVT database? Now, I would say, I'll finish with one thing. All of these trials are crossing. All these trials are crossing, okay? And the trials were designed really for TAVI, okay? So the big data is always favoring surgery, AVR, in every respect, the big data. So Partner 3 has crossed. Partner 3, if you look at the 6-year data on the FDA website, it's not a good thing. I'm telling you, it's not going to get published, okay? We see that that even with the crummy surgical arm, that the Evolute trial is now equal, will probably be crossing by next year. Notion is crossed at between 6 months and 12 months. This is what there's no long-term data that's going to support TAVI in these young patients. That's why there's guidelines. It's basically there's nothing in the guidelines that says that a 60-year-old healthy person should be getting a TAVR, even though I love TAVR.
Thank you very much, both of you, for a lively discussion. I should say, I hope that in the next trial that you will design for people around 60-year-old, you also take into account the patient perspective and also productivity. And what you mentioned in the beginning of your talk has to do with the fact that people tend to think, the patients tend to have a different perspective that's much more dominated by being able to be productive and lead a full life. And of course there we need to help them to see the risk in avoiding risk and balancing those risks. So thank you very much.
Okay, one quick thing regarding patients' perspectives. Patients are tremendously biased by statements like faster recovery, shorter length of stay, and that short-sightedness is leading them to compromise long-term survival. We have to be very, very careful in how we communicate with them and what we communicate to them.
And also we need the data to back that up. And I think that's important, as we can tell them it's not only about fast recovery, but it's about sustainable recovery and leading a long and healthy life for as long as possible.
We asked the audience just briefly. By show of hands at the beginning, I noticed that most people in the audience were younger than 60. So after hearing the debate, if you needed AVR now, can you show your hands if you would choose TAVR? TAVR. I lost the debate. I'll choose TAVR. I'll choose a clinical trial, to be honest. If I had a clinical trial, I would want to be enrolled in the clinical trial. That's my answer. Thanks.
Okay, I think we're going to move on to the next debate. I'd invite Gaurav up to the podium. We're going to be debating the best treatment options for mitral annular calcification. And so the first position will be TMVR is the best option for the treatment of MAC.
Okay, this is Juan Amanya's talk. Should I try? Let me try. About Maze. Let's see if I could get a different talk here. This mouse is not working. I have the answer right here. So.
If possible, we could keep the talks to 10 minutes to leave a little more time for discussion.
Okay.
Thank you.
We'll move along. I like how they tell us that once the slides have been made, right? So, hopefully this doesn't count for my time. Okay, so I was asked to talk about TMVR, so I'm going to move this along pretty quickly. And really what I want to focus on is really talking about Big Mac. So here are disclosures. One thing I want to highlight, this is data actually from Myra from a while back. I want to highlight, even in patients where TMVR is treated in the least invasive way, percutaneously with a valve replacement, at 5 years, 2/3 of these patients are dead. So you get a great result. MAC is bad. There's other issues with these patients. So what kind of MAC are we talking about? Are we talking about the MAC on the left, just a little bit of MAC, moderate MAC, or are we talking about the MAC on the right, which is really severe? So I call this on the left, this is baby MAC. And on the right, this is the Big Mac. So baby MAC, that's something that we can deal with. This is a patient that has some MAC on the posterior leaflet and causing the MR, and we can actually debride it using Sonopet, reattach the valve, and end up with a good result. That's not what I want to talk about. I want to talk about the Big Mac. One thing I also want to highlight, what does our cardiology colleagues, what do their literature show? And they don't really talk a lot about surgical mitral valve replacement in the high-risk patients with MAC. And if you look very carefully, way down here, there's one option for high-risk surgery. Everything else, TEER if it's not perfect, TMVR trial. So the whole industry and vision for MAC is definitely moving towards a transcatheter approach. Of course, a more circumferential MAC. This is Big Mac. As a high-risk patient, we're thinking about a TMVR. early experience with TMVR. I'm sure Yoshi's going to talk about high risk, 30% mortality in our first go with this. This is a purely percutaneous approach. They had issues with LVOT obstruction. They had issues with paravalvular leak. Sorry, your children here. Okay. Of course, we can do this with surgery through less invasive techniques where we can address some of those things, and we use what I call a Philp pellet technique, and I'll show a video of that. So this is a high-risk patient.
Started by excising.
Maybe we can take the volume off, but essentially we cut the anterior leaflet, part of the anterior leaflet out, and some of the keys is actually removing removing the papillary muscles, and then we can size it. Looks like the video's not very happy, so, and then here's the key is placing felt both in the anterior and posterior annulus.
Minimize paravalvular leak.
And that prevents the leak. This is a landing zone, or we call it the felt pillow technique, and then deploy the valve.
It is important.
And that can lead to a nice result with minimal paravalvular leak, and of course addressing the issues with LV tract obstruction. You can even remove septum through this. So what are the outcomes with that approach? And that is also a high-risk operation. In our early experience, the mortality was 13% at 30 days, operative mortality, but importantly at 1 year, 30%. So really still a high-risk procedure. And one of Yoshi's paper himself even said that we can improve these outcomes with a transcatheter approach down to 3% mortality. Let's move on to even more significant MAC. This is horrific MAC. So we went from baby MAC, big MAC, now we're talking about horrific MAC. This is something that we really don't want to see in the OR, at least not with our own eyes. We prefer to do this through a transcatheter approach. Unfortunately, there are new devices coming out, so I'm going to mention a bit about Tendyne. Tendyne is a transapical approach, and the future is definitely going to be transfemoral, but this is designed in a way to really fit the contour of challenging anatomy like this horrific MAC. And there's been a trial that's been completed, the Summit trial with the MAC arm, and we're just starting to get this data, and I can just share so far what's been presented, but we're talking about pretty significant amount of MAC, as high as 38,000 cubic millimeters of mitral anterior calcification. So again, things that we don't really want to see in an open operation. The initial series of patients that are in this trial are very high risk. They have a mortality predicted of 7%. Their 30-day outcomes with the Tendyne valve is about that, so it's still a high-risk procedure. But you can see almost none of them needed to go on pump or needed open operation. One nice thing about all these transcatheter valves is we eliminate MR. The valve works. We just got to figure out a way to put it in more safely with less morbidity. And as a result, there's multiple devices. The Apollo trial includes a MAC arm, and this is a transfemoral approach. The Alta valve also is really focusing on MAC. And oh, by the way, who's the PI of that trial? It's Dr. Kaneko. And Sophia has their own experience with severe MAC. So as I mentioned, all these companies are moving in that way. And if we look forward, what is the investment in MAC? It's all in the transcatheter space. Multiple different valves are being designed to address this population that we don't want to see in the operating room. And how much investment, let me ask, are there in surgical tools for MAC? There really aren't. Beside some off-label devices like CUSA and Sonopet that we're using, there really isn't, unfortunately, much investment in that space. So to conclude, first of all, I didn't really talk about the incidence and diagnosis of MAC is absolutely increasing. I think many of us are seeing it more and more, and it is a marker for poor long-term outcomes, not just in the short term around the operation, but at 1 year, 5 years. Those patients do poorly. They have diastolic dysfunction. Baby MAC, we can handle well. We can resect, we can use Sonopet, we can even preserve and repair valves. But big MAC, really, we have to be thinking about transcatheter options. SAPIEN 3, either through a percutaneous or through a surgical approach, can be used in selected patients with variable success. But dedicated devices for TMVR and MAC is really the future. Thank you.
Okay, we're going to hear from the surgical side, from Yoshi. And thank you for staying on time.
I didn't like that picture, Gaurav, so switch it to a different picture next time. That would be greatly appreciated. Yeah, that's me, yes. It's not showing over there in the meeting? Oh, it is showing. Okay, great. So, open surgery is only approach to MAC. Only, I don't know about it, but yeah, I'm going to try to prove the case that surgery is really effective. So this is what MAC looks like. Gaurav showed a couple of the pictures. What's really special about this MAC, since we're in Egypt, I thought I would show this. This is actually a CT scan of a mummy, and this is what the MAC had been shown. So the MAC has been present for a long period of time for the human beings. And as Gaurav said, there's a lot of different types of MAC. There's small MACs and there's large MACs. And some of the MACs does go into the left ventricle, and those are the ones that are really hard to treat. And there's been multiple surgical ways that's been described to do this. And since Dr. Melnichek is on the audience, I thought I would show the video that I borrowed from him. But there are ways to completely resect the MAC. He does it with a bovie. He takes it out. I can't do it this well, so I thought I would show the picture that the video that he had done. But you can take the complete piece out of it and then reconstruct with a pericardium and then place the valve to follow. And if you can do this really safely, the outcomes are really good. Some of the literature in the past have published a 30-day mortality of 8.6%. Again, these are much, much higher than what Gaurav had shown, but if you do it right, just like Dr. Melnichek does, in a way to reconstruct it with a complete resection, then you can do it with a very low mortality of 30-day mortality of about 5%. And also, there is a risk of AV dissociation and also long pump time, but as better as you can get, the more you do, I think you can minimize some of these complications by doing this. Gaurav already showed the video of ultrasonic aspiration. Again, I don't have a great video of this, so I borrowed it from Dr. Gerson, who's a very good surgeon. And he did it through sternotomy on this particular case, but he uses the Sonopet, and you don't really have to take the whole calcium. I think that's the virtue of this Sonopet ultrasonic aspiration technique. You can decalcify to a level where you can actually put the needle through. There are special needles that are made to go through these calciums, made by J&J, called V7 needles, and you can put those needles through after you decalcify to a certain point, and then you can place the valve sort of in a standard fashion. So you can actually go through the calcium using some of these special needles, and that way you can minimize the amount of decalcification, and people think that the AV dissociation risk will be lower. So the 30-day mortality in one series was described as 16%, but if you do it in a different way, the risk of some of these risks are high, but from an institution that Dr. Alawati is from has published a 0% operative mortality risk using the ultrasonic aspirator. So if you do it following a certain technique, you want to minimize the amount of decalcification and avoid the torque of some of the suturing. You can minimize the risk of these type of operations. We did look at the mitral valve surgery through an STS database and saw that MAC was a risk factor. There was about 24% increase in mortality at 30 days. So if you have any degree of MAC, it does become a risk factor. And this film has already been shown. This is one of my own case that we did back in the days. We can put one of the first pathway that was shown is to do a balloon expandable valve. And I think the original series were done mostly from transapical, but we found that some of these transapical techniques have high mortality risks, so people switched to a transeptal approach. Part of the problem about the transeptal approach is that it is a high-risk procedure, as Dr. Alawati shown. And this is from the TVT registry. Compared to other mitral valve and valve or valve and ring or native valve procedures, valve and MAC really has not grown over the past few years. It's completely static, meaning that people are not really doing these using the commercial platform because
Amara Guerrero's paper had shown that valve in MAC has really bad outcomes. And the problem about these procedures is that in the first 30 to 60 days, there's a lot of complications. One other thing that Gaurav did not talk about is the risk of LVOT obstruction, which is a big, big problem when you do a transcatheter mitral valve replacement technique. So if you put a transcatheter valve inside, then the anterior leaflet of the mitral valve gets pushed towards the LVOT, and it can actually block the pathway. This does not happen in surgical mitral valve replacement because you take those leaflets out. So literally, there is no LVOT obstruction unless if you put the strut in front of the LVOT. So people have looked at the TMVR clinical trials, Tendyne trial, which Dr. Alawadi is the national PI of. All these clinical trials, they've had a lot of clinical exclusions when they were doing the selection process. The acceptance rate of these trials were less than 30%. So there were 3 key exclusions to these trials. One of them was LVOT obstruction. 40% of the patients were excluded because of the LVOT obstruction, and 17% were because the mitral valve were just too big. These valves are just not made that big. And the third problem that we're talking about is the MAC. In the earlier series, the MAC was an exclusion criteria, and this was one of the big reasons why TMVR was not really expanded in the earlier series. So Gaurav already explained this, transatrial TMVR. I do this procedure also very frequently, and whenever they have a risk of LVOT obstruction, again, if you put a catheter valve in this location, you can see that the anterior leaflet will be completely pushed and will obstruct that LVOT. So in this particular case, I did also a septomyectomy to begin with, because that will increase that LVOT area. You don't have to do a full septomyectomy. You just need to do like 5 or 7 millimeters just to make sure that you don't create that VSD. And after this, the way that I do it, I don't do it like Gaurav does, but the way that I have learned is to put a felt around to reinforce, and then just run it. So the felt is on the valve side. I think his way, he puts it on the valve side, the annular side. And the valve implantation is similar to what everybody does. You want to align that commissure. But the way that you can do it is that you can go very slow and make sure that it is in the right place when you're inflating. So you don't have to worry about rapid pacing. The heart's already arrested. So you can do it much more accurately. This is actually a very cool video. So this case we did the septomyectomy. So we're seeing through the aortotomy, and this is the Neal LVOT that after the transcatheter mitral valve replacement. So you can see that there's a good amount of space that is open, and if that patient did not have that anterior leaflet resected, you would see the entire anterior leaflet from this view, meaning that the patient probably would have had LVOT obstruction. So one of the things that I started to do recently is that I started adding a pericardial cuff to the valve, because I had a couple of cases which ended up with severe paravalvular leaks. And these were patients with very large annular size and had a high risk for obstruction. So now, in those cases where I think where I predict that the LVOT obstruction, the paravalvular leak rate is going to be high, I place a pericardial cuff on the TAVR valve before deployment, and then I suture them to the left atrium. That has worked very well. It takes a little longer time, but it does eliminate the risk of paravalvular leak afterwards. So in certain cases, I've done some of these additional procedures to minimize the risk. The good part about this procedure is that you can minimize the risk of AV dissociation. So this is one of the post-op echoes. You can see that the LVOT is wide open because we resected the valve. And Gaurav already showed this, but we have gotten really better at this procedure. When we first started, I don't think we really knew how to do it. The mortality risk was 25%, but now over the past 5 years, the risk has gone down to literally less than 5%. So I think this is a very, very good technique to utilize, not in all patients, but for certain patients. I think it's a very, very useful technique. Myra and Isaac George from Columbia had published the classification of MAC. There are green MAC, yellow MAC, and red MAC. And you want to do on the green MACs with some of these features when you select some of these patients for certain procedures. These are green MAC features for transatrial TMVR, and you want to look at some of these features. I did have to talk about AltaValve, Gaurav. I know that I was on the surgical side, but I did have to talk about it. AltaValve is a very unique valve, which all the other valves are placed in the mitral valve. AltaValve is placed in the left atrium. So this is like a stent ball that expands in the left atrium. The good part about this AltaValve is that it does not go into the LVOT. So the LVOT obstruction risk is almost non-existent. And I think the other feature is that it is like the cage conforms to the MAC, so it sort of acts like a TAVR. And its location, depending on where it is, it's going to fit into that calcification. So I'm not going to go through some of these features to save time for a conversation, but this is what it looks like after the implant. You can see the significant MAC, and there is a MAC arm for these clinical trials. So again, it sort of went away from my original title. Surgery is the only option. I think we have to have multiple strategies to tackle this really difficult problem. So thank you very much.
Thank you very much. We have time for questions.
So based on your last 3 slides, it's clear that transcatheter mitral valve replacement for Big Mac and horrific Mac is really something that you're thinking about too. I think all of us, maybe a general question, how many of you feel like you're seeing more Mac now than maybe 5 years ago? So most of the people in the room, it's I don't know if the incidence is actually increasing, and I've seen that CT before, so thank you for sharing that. It's been around for centuries, thousands of years, millennium, but we're seeing it a lot more, or the diagnosis is more, and there's less of a concern about referring patients because people like Dr. Kaneko says, open for business, and we're seeing a lot more of it, so this is a real challenge.
And I think we see it more on morbidly obese patients, end-stage renal disease, some inflammatory disease, and I think that patient population is just increasing. So I think that's going to explode.
Yeah, this is important. Yeah, we see it. I mean, women, older women, maybe some renal insufficiency, certainly radiation. Those are all kind of risk factors. After having a lot of experience with the mitral approach, we've learned the hard way about some patients you maybe want to avoid, and those are patients that have PA pressures that are very high, 70, 80, 90. They struggle. They have a lot of diastolic dysfunction. You can get them through the actual valve procedure, but they end up having all types of challenges.
Thank you. Thank you both for a great presentation. Thank you for seeing my video. My question is to Myra, actually, about using calcium score and correlation to the Guerrero score, and whether you see some association there. That's one thing. And second, I do agree that there are roles for 2 or 3 different techniques. There is a role for resection in younger patients, Barrow's patients. There is a role for partial debridement with CUSA, and there is a role for Citral, as we know. But I would want to know what
Do you mean the MAC score? The MAC score, the CT MAC score?
Calcium score.
Yeah, so calcium score, for the use of SAPIEN 3 aortic devices, which do not have an anchoring mechanism in MAC, which is not circular, is oval. The calcium score total number did not help us from the beginning. So we knew when we started the experience that for example, 4,000, 5,000, 6,000, it doesn't tell me anatomically is it going to anchor. You need to have enough thickness, you need to have anterior calcium at the trigons, posterior calcium. When the leaflets are calcified, in particular your trigon stenosis, that also helps you with anchoring, and the circumference, being involved. So that's why we design the CT MAC score, which is different. It does have nothing to do with the numbers, with the calcium score per se, the Hounsfield units per se. It has to do with the amount of calcium in those. And I have to say that it really works. So if it's less than 7, please do not use an aortic device, a SAPIEN 3. So the outcomes have improved. Thank you for showing the earlier experience, but I must say that we're treated 100 patients already in the mitral 2 trial, and the outcomes, are different. I cannot disclose what the outcomes are, but obviously with experience in the use of the score and other things, those outcomes are improving. And one comment about the TVT data that you mentioned, true that the number may not be going up, and the reason is because there's no MAC. The reason is those patients, thankfully, are being treated in clinical trials. We have treated 100 in mitral 2 trial, you have treated 100 in Tendyne, also 100 in Encircle, and now you have AltaValve. So the number of patients treated is increasing, but those clinical trial patients are not included in the TVT registry. So I don't know if I'm clarifying that enough, but the number is increasing. It's just not in TVT registry. It's because they are treated under a clinical trial. Thank you.
So I got a question for you. Is there any anatomy that you would not think about complete excision? If the calcium is going into the ventricle, would you not do it? Or what are the features that you look for?
So for me, what matters is 2 things. Severity of MAC, mild you can work around it, moderate you decide, and severe, and then tissue quality. So if tissue quality is good and moderate MAC, I would resect that, especially younger patient, valgus. If tissue quality is bad, I would try not to resect that and just partially debride it or work around it. So those are the only 2 variables that matter.
I would add sometimes you see the MAC going down deep into the ventricle, and I think that's dangerous if you start resecting, because you have to end up resecting all of it in order to put it back together. And the next thing you know, you're mid-ventricle trying to bring it up. So I think
You can't patch it anymore. No.
So that debate is going to be discussed in an AATS expert consensus document. Myra's on it, Sergey's on it, and Ahmed El Eshmawi is on it as well. And Sergey, I forgot how that vote ended up. I think we're gonna have to wait for that paper to come out. I think one of the frustrations and aversions to surgeons doing MAC is that it's unpredictable what's going to happen. Like currently I'm on a streak of about 15 cases where everything's fine, but the 16th case could result in a ventricular atrial rupture, and then it's not fine anymore. It's just terrible. So I think that's the major frustration. The question for both of you is, what sort of gradients do you expect after a transcatheter repair versus a surgical repair? Remember, Sergey will do a complete MAC excision and put a really big valve in.
So a transcatheter, you're talking about like a tear? Transcatheter repair?
No, probably mitral or surgical MVR.
Yeah, surgical MVR, that's a great point. Surgical MVR, if you're able to debride, resect, sonopet, whatever you're going to do, and get a large enough valve. So I think this is a big distinction between MS and MR. And I think we lump all of them together, but the 2 pathologies are very different. They're different to the ventricle in terms of how the ventricle responds. A lot of times with mitral stenosis, the extent of the MAC is a lot worse. The MAC goes into the ventricle. They have a lot more diastolic dysfunction. So I think we're lumping them. We have to be a little careful. But let's say you have MS and you can only get the smallest valve in, you're going to have a gradient, right? You will have something that you have to worry about down the road. Now, many of these patients, this is palliative surgery. They're 82 and they're highly symptomatic. We're not looking for the long term. If you're talking about the young patient, maybe a radiation, then I think we have to do everything we can to get a large valve in. The typical gradients we see with a SAPIEN valve, even a 29, because it's somewhat cylindrical and you have issues in that way, 5, 6 is not uncommon. Surgical valves probably a little bit lower unless you end up only putting the smaller valves. TEER's been a big challenge. And it can be done in MAC, and we all have plenty of cases, but it's very selective. They have to have big enough valves. And if you take the all-comers that we're looking at, most of them are going to not be eligible.
I mean, Chris, I think that's a great point, because if you do a sonopet and put a 25, you're going to end up with gradient with like 8 or 9, right, easily. When you do transatrial or citral, then it's usually 4 or 5 range, I would say. Certain cases maybe 3, but probably in that 4 or 5 range is very common.
Yeah, I think I would also add the TMVR, the transcatheter trials that are de novo, not talking about the sapien valve, we're seeing much lower gradients.
Yeah.
So I think, again, that's going to be the future.
Give me a quick comment. As Chris said, we wrote this expert consensus document which has about 33 recommendations on how to deal with MAC. Almost 99% of them are surgical.
Yeah.
There's a part for the hyper and also a little bit about the transcatheter procedure. But from our Mount Sinai experience, like we went through the learning curve, as Gaurav said, very painful learning curve because you see a lot of mortality, morbidity, LV obstruction, disruptions, paravalvular leak. Those patients are very sick. The biggest lesson I've learned in MAC is patient selection, as Gaurav has said. Don't operate on patients who are not going to get better. No matter what you do on the mitral valve level, the 1-year mortality was 30% in your clinic because we know MAC is a progressive disease and it's just a marker of advanced cardiovascular disease. It has been proven in the Framingham heart trial, and we know this dose response curve. Those terrible patient or horrific patient with MAC, they have extensive amount of MAC, and that will dictate the 1-year survival. You can get them through surgery, high mortality, morbidity, but again, you might not change anything at 1 year. And a lot of patients don't get symptomatic improvement because of pulmonary hypertension and diastolic dysfunction. So we almost never operate now unless the patient is very symptomatic with compromised quality of life. We don't do sort of, early MAC surgery. There's nothing that goes like that. And the way I see MAC is a surgical disease. I'm very frustrated with the transcatheter therapy and even the hyper procedure because it's still a surgical disease. The reason we wrote the guidelines, or we wrote these consensus documents, because we have to provide armamentarium of procedures so surgeons can be trained to do this, because you have a huge number of patients coming and surgeons are reluctant to operate on these patients. So hopefully that will be a guidance to support that.
Your point is absolutely valid. I mean, I think we're all seeing a lot more of MAC. Surgery still has a real important role until the transcatheter devices. And you're right, the screen failure rate's high. 80% in the Summit trial were screened out for MAC. So, and that, you're seeing that with all the different trials. Maybe Alto will be different. But where we lack is that the companies have not modified things to help us. I mean, how easy would it be for the sapien valve to be modified, to have a better cuff that we can deploy surgically, even tilted so it's away from the LVOT, a better cuff that's already pre-designed. We talked to the companies and they're not interested, but with the incidence rising, with the power of the people here, HVS, other societies, I think we have to push Edwards to look at that.
Yeah, and I think we got to separate some of these younger MAC patients to older MAC patients. You don't want to do those full resections on older patients. I don't think that's going to end up well. I did review that paper, so it's a very good paper. I recommend everybody to read it. I think it's going to come out.
Can I ask you both a quick question before we wrap up? The cardiologists and surgeons seem to think about MAC as a disease differently than, say, rheumatic mitral stenosis when they think about gradients. So what is the current indication that you use to decide when to operate by gradient, amount of MR, mixed disease, symptoms, PA pressures, et cetera?
You want to go first?
So, I mean, first of all, they have to be symptomatic. As Ahmed said, I don't care if the gradient is 12, if they're not, and there are a few patients like that, pretty active people that have severe radiation, 45-year-old person that I'm following for years now. She's high up in the Michigan legislature. We're not operating because she's exercising, and we're not going to put the patient through that risk. So I think first is symptoms, and the second is you have to justify that the valve's bad enough. There's another patient I'm following right now who's very symptomatic. Every echo shows a gradient is 6. So now we're doing more invasive measurements because I'm not going to put that. I want to make sure that they're going to feel better at the end, because at the end I'm going to put a sapien valve in, and the gradient will be 5 or 6, and is that going to help them, or she's going to still be symptomatic? So they have to have both those two.
Mark, I think the MR ones are easier. So if they have severe MAC but severe MR and symptomatic, it's probably from that. That's easy. Yeah. But the ones that are hard is there's no MR, and the mean gradient's 7 and has severe MAC. We really have to be careful on those. I mean, those could be from their age. Sometimes they're just body habitus. The symptomatology could be coming from that. And I think that's the one that you really need to investigate, because the last thing you want to do is you treat them and undergo these really high-risk cases and then end up with no symptomatic relief.
One prediction that I have is that no clinical trial is going to show the improved survival on these patients, whether you treat them with surgery or transcatheter. I think at the most that we can hope it will be similar to the transcatheter interventions trial, where you improvement symptoms and quality of life than unnecessary survival. There's all little women with multiple comorbidities. At 5 years, there's going to be, death loss, unfortunately.
Now we move to the third debate, that every patient undergoing valve replacement should have breast procedure, or we have to keep that only for patients who had previously atrial fibrillation.
Dr. Malazer, you're up next.
Okay, atrial fibrillation. This is going to be a good debate, so get your mind wrapped around this. So you have a valve patient who's going to surgery already, whether or not they have AFib or not. I'm going to argue that you should do some sort of atrial fibrillation ablation. Okay, I'm going to argue that. And here are my disclosures. So I'm going to be arguing a point that is not FDA approved and it is not guideline driven. And my other disclosure is that Juan Pablo is a good friend. Where'd he go? Go back there. JP is a good friend of mine, and to quote another famous cardiac surgeon, if you can't screw your friend, who can you screw? So we're going to go after this one here. Since I'm on the minority side of this, can I get a show of hands? So if you have a patient without atrial fibrillation who needs valve surgery, who would do an AF ablation for that case? Okay, no appendage. AF ablation, like you're gonna create lesion lines. Would anyone do that? So I got two. So I'm going to win this one. I just have to change like a couple people's opinions here. Okay. All right, here's the overview of my talk. This is what I'm going to argue. So valve patients without preoperative atrial fibrillation have a high risk of developing postoperative atrial fibrillation, so POAF. Some people call it new onset atrial fibrillation or de novo atrial fibrillation. Point two, I will argue, is that POAF is associated with a higher resource utilization and poor outcomes. I'll show you some data on that. And published studies support an argument for what we would call prophylactic AF ablation and LA occlusion. So prophylactic, you heard it here, prophylactic AF ablation, that's a concept. Okay, so prevalence of AF before valve surgery is about 30 to 40%. So you have a valve patient, 30 to 40% of patients will have preoperative atrial fibrillation. The guidelines for concomitant atrial fibrillation are very clear. You should do it. So these are guidelines from the cardiologists. And the Americans give it a class 2. Europeans are a little bit more progressive. For mitral valve surgery, it's a class 1 indication to do it to restore normal sinus rhythm. Surgeons are a little bit more prescriptive, more class 1 recommendations for concomitant AF for the purposes of not only restoration of normal sinus, but also improvement in survival. Okay, so we'll start with that. Concomitant LAAO, this was published by STS, receives a class 1 indication based on the LEOS 3 trial. So there's no argument that if you have a valve patient with concomitant atrial fibrillation, that patient should get ablated. All right, so there's no question there. But what about the other 60% of patients who don't have atrial fibrillation that you have to do valve surgery on? So here's my argument. So number one, valve patients without concomitant AF have a high risk of developing POAF. So what do you guys quote your patients for postoperative atrial fibrillation? Maybe about, I quote 25%. So here's what the data shows. Incidence of POAF is about 30%. And this is compared to patients who have non-cardiac surgery. That risk is only 3%, so which you consider patients who have cardiac surgery has an incidence of 30%. The biggest risk factor for getting POF is the patients having cardiac surgery. So that's the biggest risk factor. That risk is even higher for valve surgery. And this is recent data. This is quoted all the time. You're going to get this thrown at you all the time. Evolute on the left, Partner 3 on the right. Incidence of POAF after surgical valve is about 40%, a lot more than after TAVI. So it's higher. Okay, argument number 2. POAF is associated with bad outcomes. The first one is resource utilization stinks. I don't like POAF because I could pretty much count on the fact that the patient's not going to go home in 3 to 5 days. They're going to go home like 5 or 7 days because your PA has to manage the amiodarone. Someone's got to get cardioverted, like the cardiovert patients before they go home. This all leads to more money, so higher resource utilization. This is a meta-analysis studying mortality for patients who do get POAF. And this is a relative risk, so increase of 37%. That seems pretty severe. It's probably true, but the absolute number isn't that high. So this is a recent publication showing a statistically significant higher rate of mortality if you get POAF. Absolute number is about 4%, but yet that number is still there. So higher resource utilization and worse outcomes if you get POAF. Okay, so what is the current data that suggests that prophylactic AF could be beneficial? Well, here's a meta-analysis looking at 7 studies, particularly patients without preoperative atrial fibrillation, and what happens if you do prophylactic AF ablation. Well, long and short of it is it does reduce the rate of POAF. So that makes sense. You do ablation lines, patient has less likely of getting POAF. And here is, I think I quoted the wrong one. Okay. Yeah, okay, so quoted the wrong one. So here, this is looking at just prophylactic left atrial appendage occlusion. And Pat McCarthy published this showing a reduction in stroke and death. Possibly, this is not randomized clinical trial. So this is prophylactic LAO occlusion, which has led to the LEAPS trial, which is about 2/3 enrolled at this point, specifically looking at this. And this is a randomized clinical trial. Patients who are getting cardiac surgery, they either get LAO occlusion only versus no LAO occlusion. So that trial is about to be completed. Now, what about ablation itself? Sorry to get people discombobulated. I'm a little bit confused. What about the atrial fibrillation itself? This is looking at 7 studies, looking at the benefit of doing ablation lines, and there is a benefit in reduction of POAF. So that's good. That's good. I just talked to Tomas Tomek, who published this with Charles Wilkes. This is the most recent study randomizing patients to get prophylactic AF ablation. And it also showed a reduction in POAF, but they also called for a randomized clinical trial. And that one, per report, will start by AtriCure as a sponsor as soon as LEAPS is ended. So I'd like to randomize in that. So Tomas Tomek at Michigan. Okay, so why is this good? I'll show you some surgical videos. I always have some surgical videos. PVI is pretty easy to perform. This is the right PVI. I'm getting into Waterston's groove here because you want to get up to the left atrium, away from the pulmonary veins. You also don't want to clamp on fat. Put the clamp up high next to the heart. I do 2 applications without unclamping. And then you do 3 sets of 2 applications, and you reposition in between. You reposition closer to the heart. On the left side is also fairly easy. So here's a left pulmonary vein isolation. The left pulmonary veins are towards me. The label should come up there. So you do 3 sets of 2 applications as well, unclamp between sets. So it's fairly straightforward to do. Left atrial appendage closure is also very quick to do. So here are my conclusions. Again, valve patients without preoperative atrial fibrillation have a high risk of developing POAF. POAF is bad, higher resource utilization, and it's also associated with poor outcomes in terms of mortality. There are published studies now that show that you can get restoration of normal sinus rhythm and reduction in POF, but no studies yet showing an improvement in outcomes. And therefore, I think this sets the stage for a randomized clinical trial. If you like these figures, come to my next talk at 3 p.m. All the figures will be available by the end of the year in Dr. Cox's textbook. Thank you very much.
Next speaker, John Babner.
So imagine if Chris got confused. I can't imagine how you guys are feeling. But let me give you some clarity. How do we get into I know. All right, so let me try to make this brief, and Chris made it very easy. These are my disclosures. AFib, as Chris said, is bad. It's a global epidemic. It's growing, same as obesity and everything else. Leads to a 1.52 times increase in mortality, 2.5 increase incidence of stroke, and over 5 times lifetime risk of developing heart failure. And of course, the treatment of it and the care of those patients is tremendously expensive. It takes about 3 times as much to care for a patient with AFib than it does for a patient without AFib. Now, with that epidemic, what we see, of course, is a gradual but very slow increase in the number of patients that get ablated concomitantly with cardiac surgery. Whereas the total number of patients presenting with concomitant AF has been growing steadily, together with that global growth in the incidence of AFib, which results in a slowly trending down of the incidence of concomitant AFib ablation. And that, when you look at the ablation per procedure, you can see that, of course, any patient who has a mitral valve procedure, either concomitantly with CABG or isolated, will get a higher incidence of concomitant ablation, whereas patients that don't need to have their atria opened will or are unlikely to get a concomitant surgical ablation. So what has the evolution been in terms of concomitant ablation? 2012, this consensus statement said that it was advisable for all patients with documented AFib referred for surgery to undergo a procedure for AFib. And this was the Heart Rhythm Society. And ablation trends, as a consequence, together with the advent of new technologies, have gradually been increasing up to 2014, as you see there. But what do the guidelines say? Thank you, Chris, for that beautiful introduction. That actually makes it very easy. You saw this, 2017, they came out and recommended for mitral valve surgery, CABG AVR and CABG and AVR. It appeared not to increase morbidity or mortality during surgery. As a consequence, they reached a class 1, level A and level B recommendation. And the update that was published by Vinay Badawar and his team in 2023 basically states what Chris already showed you. With mitral surgery or any other type of surgery, first time non-emergent, you should do a concomitant surgical ablation, or at least you should do a left atrial appendage occlusion. And the thing that was added is a heart team approach to the treatment of AFib in cardiac surgical patients. So in summary, in 2025, we must have a very valid reason for not performing concomitant AFib surgery in patients with a history of AFib who are undergoing cardiac surgery. Otherwise, we would not be providing an acceptable standard of care to our patients. And what should we do? There's a beautiful paper published by Dr. Cox and Chris showing the reentry circuits that lead to AF and how a biatrial maze with left atrial occlusion using a clip gradually get complete silence, electrical silence of the left atrium, as you can see there, followed by the right. So this is the standard of care for persistent AFib. Now, if you're dealing with paroxysmal AFib, a PVI and left atrial appendage occlusion is the way to go, and you probably should do a box lesion, which is most effective, versus isolated isolation, as it were, of the pulmonary veins. The benefits of surgical ablation, we already know. It's rhythm control, stroke prevention, and improvement in survival. This paper in 2017 showed how the freedom from atrial tachyarrhythmias reaches 80% at 5 years. And when you look at the prevention of stroke, which is one of the things that we're looking for, of course, this very large study, over 100,000 Medicare patients published recently, shows how survival free of stroke is much better, significantly better, in patients undergoing a full biatrial maze compared to left atrial appendage occlusion or no AFib treatment. And the same applies to survival. You can see there are multiple studies showing that at 10 years, there's a 20% higher or better survival when you treat these patients concomitantly. And this, again, was corroborated by this paper by Vinay Badwar and Mahaffey, showing that survival when you do biatrial maze is significantly better than just left atrial appendage occlusion or no AFib treatment. Now, you might argue that this is true for America, not for the rest of the world. Well, this multi-center trial from Europe shows exactly the same thing. You can clearly see that there's a benefit in survival. But the real question is whether it's safe or not. If we're going to be applying it to patients who do not have a history of AFib, is it safe? And I think Chris's answer would have been the same as Dustin Hoffman's Marathon Man. It's really safe. No, not that safe. Not safe at all. I'll argue that it might not be safe enough yet. The risk of surgical ablation of AFib lead to a higher incidence of AKI, longer CPB times, whether we think of it or whether we actually admit it or not, and more bleeding, and I'll show you why. But this paper by Damiano's team, published in 2022, shows clearly that the incidence of acute kidney injury is significantly higher in patients undergoing a biatrial maze or a Cox maze 4 procedure during cardiac surgery. It does not lead to higher long-standing renal failure or a need for dialysis, but it does impact survival. When you look at the two groups of patients that have undergone concomitant AFib ablation, you see that patients who develop AKI have significantly lower survival than those that did not. Now, the benefit overall is so important that overall survival, when you compare non-AFib treatment versus AFib treatment, AFib, or patients who undergo AFib ablation, live longer and have a better long-term survival. So, but bear in mind that it's not harmless. AKI is a real thing and will impact survival in that group of patients. Now, what about prophylactic AFib ablation? We saw, Chris showed you this paper by the team out of Grand Rapids. And when you actually look at the data, you see that cross-clamp times and cardiopulmonary bypass times are significantly longer. The transfusion requirements significantly higher, and length of stay significantly longer. So the first argument, which is do an ablation prophylactically to decrease resource utilization, decrease length of stay, maybe doesn't apply. So in summary, concomitant AFib ablation does improve survival, but it does carry a risk, the most significant of which is development of acute kidney injury. It leads to longer CPB times, bleeding, and length of stays. As a consequence, the risk-benefit ratio must be carefully assessed and ablation applied accordingly. Now, are we doing enough is the real question. And there's a clear undertreatment of AFib. So even in patients that should get ablated, we're not doing it. You see that when we add up left atrial appendage occlusion plus a complete set of ablation lesions, the no treatment arm or group of patients is decreasing. But when you look at the actual numbers, whereas patients who undergo mitral valve procedures will get up into the 70% range of AFib, of concomitant AFib ablation, when you come to the patients that undergo CABG and have preoperative AFib, only about 30% get treated. And when you look at Europe, it's actually worse. And you're talking about 20% versus about 6%. So I think the key takeaways to this is that we should first try to do no harm. Performing a surgical ablation for concomitant AFib in a greater proportion of patients, as indicated, is what we should aim for, or at least do a left atrial appendage occlusion in 100% of patients with concomitant AFib. And only then think about prophylactic left atrial appendage occlusion, maybe. In my mind, prophylactic ablation is a little bit like prophylactic tooth extraction. Let's get people to brush their teeth, and then we can get a little bit more aggressive. Thank you very much.
Great discussion, Chris and Nguyen. So my main issue is the prophylactic MACE, and we do a lot of them at Mount Sinai, as you know. Like the main worry that I think I don't know, one didn't mention it. What about the risk of stroke from the ablation line? Because it happened that I redid some patients who had MACEs in the first week after surgery for other reasons, and then I found a linear clotting on the left atrium, on the wall of the left atrium. Also, on the other hand, I realized you used a clamp. Why not you just do a cryomaze when you open the left atrium? And the last question is how quick you use the NOACs, and would you worry that prophylactic MACE might trigger atypical flutter, which can be more difficult to treat if we create another problem? Thank you.
Ahmed, more questions than I have answers for. So let's see, one at a time. The first one was what?
Stroke.
Stroke. The actual, if I may, I think that when you look at the data, the risk of stroke is lower when you actually do an ablation. Now, prophylactically.
In patients with AFib.
In patients with AFib. In patients with AFib, right? So the risk, the data is overwhelmingly in favor of treating those patients, and the risk of stroke is lower in the patients that are ablated versus those that are not, right? Now, I don't think, I haven't come across any studies looking at the risk of stroke if you do prophylactic ablation. But if you extrapolate the left atrial appendage closure, left atrial appendage occlusion papers, it should go down. Of course, once you do an ablation, the patients will need to be on anticoagulation, right? If you just occlude the left atrial appendage, you can forget about anticoagulation. That's of course something I should have added there, because those 3 months of anticoagulation, that's an added risk.
Yeah, you really should anticoagulate, I might agree, because you have a left atriotomy line as well, and you also anticoagulate for your mitral valves. The atrial fibrillation thing is actually interesting. So if you saw that middle panel from McCarthy's data set, there was, with just prophylactic LAAO, no ablation, patients actually had a higher risk of POAF because of inflammation, probably because of inflammation around the heart. The Mayo guys also showed that as well. So that's where the ablation lines actually come in as well. What was your third question?
The timing of NOAC.
Do you give time for, do you bench or you wait, or you give NOACs after surgery the first week? Because you want to shorten the hospital stay, right? Which is another problem that some patients, you have to wait until they are therapeutic.
Do you use Coumadin? Do you use NOACs? I guess maybe let's say for a bioprosthetic valve.
Yeah, I'll send them. This is just practice patterns. We should ask everyone. I send everyone home on Coumadin. I don't wait for levels. I just send them home. Unless they're on NOAC preoperatively, then I put them back on their NOAC. Easy. What do you do?
We do NOACs 48 hours after. We start NOACs 48 hours after, or if no AFib, and you can pull the wires. But as soon as the wires are out, I start NOACs the next morning.
And you never regretted the one?
Not so far, should I?
I wait
no.
5 days for no
The
after when I
last thing
start.
is the flutter. Any issues with atypical flutter because of the maze itself? Have you seen that in your practice or no?
Yes, yeah, and that's why I think the two isthmus lines are particularly important. Where you do it is debatable. I think that the classic left atrial, left mitral, the mitral valve isthmus line, doing it from the outside and then that inside has been shown to lead to more gaps. There's a higher incidence of gaps than if you do it the way Sherman has advocated with the Tampa procedure, which implies just doing that ablation line a little bit like the evolution on the right side to the tricuspid annulus. You go from the base of the left atrial appendage to the mitral valve annulus, and that appears to have a very good effect as you map those patients post-operative, which Sherman does very nicely with his EP team.
Okay, we have to break up soon, but there's there's two more people. Very short question, very short answer. Okay?
We're gonna have to run.
I think he was first.
So, a quick question. So, I just do MACE when patients have previous AFib, but I know surgeons are putting atrial clips prophylactically, just because they feel that it should be placed without AFib before. We know that the atrial end peptide and the beta end peptide are produced in the left atrial appendage, and there's some data that say that will change your blood pressure, your salt consumption, so that's more a basic science question, so our cardiologist can answer, what is the problem when we change those peptides, just putting atrial clip prophylactically? I mean, what is the long term? Because I don't think the AtriCure paper will touch that part. I mean, we know that will decrease the stroke rate, but what about the other things that we're taking away?
Yeah, I think minimal because the atrial peptides also come from the right atrial appendage. We're not clipping that. Short answer.
Great. And then there's...
Talk about pacemaker. You do an ablation, you increase the risk of pacemaker, CTS central, biatrial pacemaker risk with a mitral and tricuspid is 20%. Where does that fall into your algorithm? Maybe it's really for Chris. I mean, where does it fall in your algorithm? Are you concerned about that at all?
Yeah, we don't agree with your CTS paper that you guys try to publish there. All right? You're missing the point. It was beneficial for your outcomes. And then you guys are doing it wrong. Yeah.
So if we're going to get all sentimental and start holding hands and sing Kumbaya, I think that the real thing to do if you're going to do prophylactic AFib ablation is maybe using the Encompass clamp and just and that so far hasn't shown to increase the risk of pacemaker replacement. I was expecting Chris to talk about that, so I didn't add it because I didn't have a very strong argument there.
Okay, all right. This is the answer. You tell your cardiologist the maze does not cause heart block. Those lesions do not cause heart block. The reason you get pacemaker is because you've unmasked underlying SA node dysfunction that you did not see. That's why you get a pacemaker. The maze
not
does
all
not
the patients were in permanent AFib. So even in paroxysmal, you do see it sometimes. And I agree with you, done right, you're not supposed to. But there are people going to heart block you don't even do a maze on.
Yeah.
And you're doing valve surgery, right? So there's a lot of things going on.
One final burning question, and then they have to answer yes or no, okay?
Okay. Yeah, I was wondering, it might be a naive question, I'm relatively new in the clinic, but what about instead of doing a maze, doing a left posterior pericardiotomy? Because that also seems to have quite a good results in preventing AFib.
Yes, that is effective. And another randomized clinical trial, I don't even know why we need to do it. It's already been shown to be positive.
Okay, I think we had a great session. We're going to continue discussion over lunch with that's in the main building, and invite everybody.
The course of lunch is now in Canyon 3. It was going to be here, so you need to go back to Canyon for both lunches, Corsum and Artivian. Thank you.